welcome to part 1 of 2 of the presentation of the ankle. In this presentation we will review the normal anatomy, we will propose a checklist and a search strategy for image review of the ankle, we will look at Ottawa rules for image referral specifically of the ankle, and then we will also then present a series of cases with fractures to give you some experience. Here are some of the learning resources used in the creation of this presentation. Here we see a normal AP mortis view of the ankle. Take a little bit of time to refresh your memory of the normal anatomy here. You may wish to pause the video for a short time until you've completed that. And here we have the lateral view. Again, you may wish to pause the video, take a little bit of time just to remind yourself about the normal anatomy before you proceed. And finally the axial view. Again, pause the video, just take a little bit of time to make sure you're familiar with the anatomy before you proceed.
Okay, so let's run through our ankle checklist of the mortise joint. What I want you to do is to check your malleoli carefully for fractures. Does the tibiofibular syndesmosis measure 6 millimeters or less? How about the talar dome? Is it nice and smooth or is there any disruption to it? Check your medial and lateral talar processes for fragmentation. Is your mortise joint 4 millimeters or less? And are the epiphyses and physes normal? The checklist that you should carry out on your lateral view is of the tibia. You want to make sure the cortices are intact. You want to make sure the articular surface is smooth. On your fibula, check for any oblique fracture lines that you might miss. What about the talus? Is the neck intact? Do you have a normal talonavicular articulation? And on your calcaneum, check for any fracture lines. Is your volar angle reduced? And what about the anterior process of the calcaneum? Have you looked at it? And of course, always check the base of your fifth metatarsal. So we always carry out a search strategy to make sure that we carefully check all aspects of the radiograph. So A is for adequate. Is the area of interest included on the image or do you need further views? A is for alignment. Do the opposing bones articulate with each other? B is for bones. Are there any breakers in the cortex? Is the trabecular pattern clearly demonstrated? Is there any increase in sclerosis which might indicate that the trabeculae has become impacted? C is for cartilage or joints. Is there loss of joint space or diastasis? And S is for soft tissues. Is there any swelling that might help you guide you towards an underlying fracture? It's important to take good quality radiographs, as inadequate imaging can mean that subtle injuries can be overlooked. Let's have a look at this ankle x-ray. The lateral view is under-rotated, and we know that because we can see both the anterior and posterior cortices of the talar dome. A good quality lateral ankle view will have a lateral ankle joint. Some people think that you need to get the fibula projected behind the tibia for a good quality lateral ankle, but that's not so. It's the ankle joint that we specifically want to be lateral. To position a good quality lateral ankle, you want to make sure that the lateral border of the foot is in contact with the receptor. If the patient's toes are touching receptor, that means that the patient is over-rotated. And conversely, if the lateral border of the foot isn't against the receptor, then it will be under-rotated. Okay, now let's look at our mortise view, and this really is very poor quality. We can see that there's gross soft tissue swelling over the lateral malleolus, but we can't actually visualise the tip of the lateral malleolus because this patient has the calcaneum projecting above it. You need to do repeat views because we have to be able to visualise the tip of the fibula. And now with a repeat mortise view, we can clearly see that there is a transverse lucent line at the tip of the lateral malleolus with a tiny break in the cortex, indicating that this is an undisplaced fracture. And the gross soft tissue swelling helps to guide us towards that injury. So what is it? It's a fracture where it's the tip of the lateral malleolus of the right fibula, and how it's undisplaced. I just want to spend a few moments discussing what fracture appearances look like. If you have a transverse fracture, so that this is the fibula, so this is the lateral border, and this is the tibia, so this is the medial border. So if you have a transverse fracture that passes from lateral to medial or medial to lateral, what happens is that you will see you will see a transversely or obliquely orientated fracture on your mortise view. And on the lateral view of your transverse fracture, you will see it as a horizontal line. However, if you have a fracture that runs from, so this is the dorsal cortex, so this is posterior and this is anterior to the tibia. So if you have a fracture that runs posterior to anterior, anterior to posterior, i.e. oblique fracture, like we're visualised here, you will see the oblique line on your lateral view, and let's have a look at what it might look like on the mortise view. Because the fracture line is lined from posterior to anterior, anterior to posterior, depending on which way you look at it, you're not going to get that horizontal line on your mortise view. Instead, what you get is a kind of like a ring effect as you see it en face. So if you see this kind of odd appearance on your mortise view, you need to be really suspicious of an oblique fracture running posterior to anterior, and so scrutinise your lateral view very carefully. Where you have two bones forming a ring structure, you have a high risk of incurring two or more injuries. So let's think of all the different types of ring structures we get. Well, in the ankle, you've got the tibia and the fibula. You've got the radius and the ulna in the forearm. You have the mandible and the maxilla in the face. You have the odontoid peg in the cervical spine. And then within the pelvis, you have the pelvic brim and the obturator foramina. And people often liken this sort of theory towards a polo, whereas when you take a polo, it is impossible to break it in only one place. And so therefore, you're going to get this contre-coup injury. The problem with this, though, is that we don't always get two bony breaks. And so we know this very often in the ankle, where you'll quite often get an isolated fracture of the fibula or an isolated fracture of the tibia. And so a better analogy is maybe of a bagel. It's perfectly possible to tear a bagel and not break it on the contre-coup border. However, you will get crinkling of the bagel surface. And so this is a good example of where you can get a fracture to the bone, but then you'll get ligamentous disruption in another location. And so that's a much better kind of analogy. However, we should always be careful and make sure that there is only one fracture and there are no other fracture fragments detected. We refer to the ankle as a mortise joint. We don't take an AP view of the ankle. The only time we take an AP view of the ankle is for orthopedics, and usually they will be asking for a 3 image series, so a lateral, a mortise view and an AP ankle. Now, what do we mean by the mortise? So a mortise is when you have a tenon and that gets recessed within the mortise joint. So this equivalent is the talus is recessed between the lateral and the medial malleolus. And that means that the talus is unable to move. However, if you sustain a fracture in one or more areas of the mortise, such as the lateral malleolus or the medial malleolus, this means that the talus has the ability to move in certain directions. So it's important that we make sure that the mortise joint is preserved and that there's no underlying injury. Okay, so this example demonstrates the mortise joint with the talus highlighted in green, the lateral malleolus in red. This is the bit abutting the talar dome is your tibial plafond, and then you've got your medial malleolus. And it's important that this structure remains intact, because otherwise you've got a highly significant injury that won't be able to remain reduced if it's not fixed. When we evaluate ankle images, we assess the mortise joint, but also we need to assess the distal tibiofibular syndesmosis, because sometimes it's perfectly possible to have an intact ankle joint, but you have disruption to the intraosseous membrane causing diastasis to the tibiofibular syndesmosis. So when we measure the tibiofibular syndesmosis, we take, so the dense sclerotic line here, this is your tibial plafond. So we measure 1 centimetres proximal to the tibial plafond, and the gap between the distal tibia and the distal fibula should measure 6 millimetres or less. Now, obviously, during the exams, you're not going to be able to measure the tibiofibular syndesmosis, but what you can always appreciate on a mortise view is that the fibula should overlap the distal tibia. So if you see clear space between the distal tibia and the distal fibula, you know that you have disruption to the tibiofibular syndesmosis. Ankle sprain is a really common injury. We see it all the time, and it's usually caused by inversion or eversion. And a sprain is classified as an injury to soft tissues, usually the ligaments, and so what you tend to get is this real soft tissue swelling over one or both malleoli. And you may actually get a joint effusion as well. So similar to the foot, we apply Otto rules to the ankle. So this means that clinicians will not, if they apply these rules, they won't miss a significant bony injury. So the rules of the ankle are that there should be bony tenderness at the posterior edge or tip of the lateral malleolus, or bony tenderness at the posterior edge or tip of the medial malleolus. And then you've also got an inability to weight bear both immediately at the time of injury and within the emergency department, which is 4 steps. A little word of warning though, so the Ottawa rules mean that you will not miss a significant injury. However, teeny tiny avulsion fractures can be missed. And so therefore I tend to be quite sympathetic towards clinicians who don't necessarily apply the Ottawa rules, because in our increasingly litigious society, people will be trying to sue if you miss a tiny avulsion fracture of the tip of the lateral malleolus, which, even if it doesn't change clinical management, they will still allege that a fracture has been missed. So it's worth being slightly compassionate towards clinicians when they are asking for these radiographs. So here's a nice diagram demonstrating the sort of type of common fracture patterns of an inversion injury, and with increasing stress what the type of fracture patterns is like. And conversely, the bottom one, this is for eversion injuries. So I want you to be aware of this, but at the same time, in your exam, don't use the clinical indications to then stop searching for other injuries. Patients are notorious at giving poor or even incorrect clinical history. So whilst I would like you to have an understanding of these types of direction of common fracture patterns, don't use the clinical history to cloud your judgment over what fractures you'll be seeing. Okay, so here we have a transverse fracture through the lateral malleolus, and with adjacent, look at that lovely soft tissue swelling, or well, patient probably doesn't think it's lovely. The important thing with this injury is that we can see that it's inferior to the tibiofibular syndesmosis. And what this means is that the mortise joint is still preserved. So the medial malleolus, which is intact, is still preventing the talus from moving in a medial direction. And on the lateral aspect, although the inferior portion of the lateral malleolus is broken, there's enough of the distal lateral malleolus to hold the talus in place so it can't move laterally. So this is a really important thing that you should identify when you're talking about in image interpretation. So what is it? It's a fracture where it's the lateral malleolus of the right fibula distal to the tibiofibular syndesmosis. How? It's undisplaced. Okay, so this is a great example of how we've got disruption to the tibiofibular syndesmosis. We can clearly see our oblique fracture of the lateral malleolus that extends to the tibiofibular syndesmosis. Now, when we measure our mortise joint, the medial clear space, the joint space between the tibial plafond and the talar dome, and the lateral clear space should all measure 4 millimeters or less. And here we can quite clearly see that there is diastasis of the medial clear space. So what's happened is that this fracture through the lateral malleolus at the level of the tibiofibular syndesmosis means that it can no longer hold the talus within that mortise joint. And what's happened is that you now have talar shift laterally. You can't have medial talar shift because the medial malleolus is still intact. So what is it? It's a fracture where it's the lateral malleolus of the left fibula. How? It's oblique at the level of the tibiofibular syndesmosis with lateral talar shift. And it's important to comment on the lateral talar shift because this means that this is a highly unstable fracture and it needs to be reduced. So this is a really interesting case. We have an undisplaced fracture of the medial malleolus and crucially it's at the level of the tibial plafond. So even though we can see from our mortise joint that the lateral clear space, the superior clear space and the medial clear space are all preserved, they're all 4 millimeters or less, it means that though if this patient then stood up and walked on it, there's highly likely that this will then cause displacement to the fracture site, and because the medial malleolus is disrupted, it can no longer hold the talus in place medially, so there is the potential for medial talar shift. So what is it? It's a fracture where it's the medial malleolus of the right tibia at the level of the tibial plafond. How? It's minimally displaced with no talar shift. And it's important to say no talar shift because potentially this patient could be casted and hopefully wouldn't actually need wouldn't need surgery. So another common injury is that you get a fracture of the distal diaphysis of the fibula, and what happens is that this is the intraosseous membrane that runs between the lateral border of the tibia and the medial border of the fibula, and what happens is that you can get disruption to the tibiofibular syndesmosis, so it rips all the way up through that intraosseous membrane and then it rips out through the fibular fracture. So this means that this whole complex is unstable. So although this potentially looks like a normal lateral clear space, we can clearly see that the medial clear space is far greater than 4 millimeters or less. And so therefore we have got lateral talar shift. So we know that the intraosseous membrane is disrupted and it's disrupted up to the level of the fracture. Now we don't use orthopedic classification in image interpretation. There's only one orthopaedic classification that I can think of that we use, and that's for the acromioclavicular joint, so we're not going to discuss that now. But you don't need to comment on Webber classifications. So a Webber A is it's that very first image where I showed you a fracture of the fibula in distal to the tibiofibular syndesmosis, and a Webber B is then a fracture of either the medial or lateral or both malleoli at the level of the tibiofibular syndesmosis, and then a Webber C is a fracture of the distal fibula around about 4 to 7 centimetres proximal to the tibiofibular syndesmosis. So I'm very happy that you're aware about Webber classifications, but I don't want you to use Webber classifications in the exam. So what is it? It's a fracture where it's the distal third of the diaphysis of the left fibula and how it's slightly displaced with lateral talar shift. Isolated fractures of the posterior malleolus are rare. To be honest, it's not really a malleolus, it's a tuberosity, but it's so frequently called a malleolus that we just use that terminology. Generally speaking, a posterior malleolus fracture is usually associated with other fractures to the malleoli, whether that's a single malleolus or multiple. So for example, if you had a trimalleolar fracture, that's a fracture of the lateral malleolus, the medial malleolus and the posterior malleolus. It's important to be very suspicious of an isolated fracture of the posterior malleolus, and if you do have it, you will need to go on and do full-length tibia and fibula views to make sure that you don't have a high fibula fracture in addition, but I'll talk about that in a bit more detail in part 2. So here we can quite clearly see this lucent line running obliquely through the posterior malleolus. There's very slight displacement, but it's not really very significant. So when you do look, it can be quite difficult to see the posterior malleolus because quite often it's covered by the superimposition of the fibula, but do scrutinise this area carefully to make sure that you don't miss it. So what is it? It's a fracture where it's the posterior malleolus or tubercle, how slightly displaced. We've come to the end now of part 1 of the ankle, and I look forward to catching up with you with part 2.